of the peripheral morphology that we've kept for a different day. So we'll start from the basics. Again, before I start, I have no conflicts of interest to disclose. While I show graphs and histograms from a particular machine, again, this is just for ease of teaching and sharing. This is not, marketing or propaganda for any particular company. And the basic logic is that the histogram concepts across 3-part or 5-part counters, especially for RBCs and platelets, remain the same. The naming of the flags, the wordings may be slightly different, but there is not much of a difference in the concepts. So let's go back to school and understand what is a histogram. And if we were to, this chart on the bottom right, which you see, if this was the age groups of different people who are going to an ice cream parlor, so 1 to 5 years, 6 to 10 years, 11 to 15 years, 16 to 20 years, 21 to 25 years, for example, and on the y-axis of an histogram is always number or count, and x-axis the basket. So it is basically, in very simple terms, a diagram consisting of rectangles whose area of this rectangle is proportionate to the frequency or the number of that variable. In this case, it is age, okay, and whose width is equal to the class interval. So the class interval here is age groups of 1 to 5, 6 to 10, 11 to 15, so on. So simplified, a histogram is always a single parameter, statistical dot plot displaying frequency of events. So when I say single parameter, in this, the parameter evaluated is age on the x-axis, and y-axis is always frequency, count, or number. So any histogram in the world will always measure one parameter which is given on the x-axis, and the y-axis will always be the number for that parameter. So I said, if we were to survey the age group of people below 25 years having ice cream in one day at a given ice cream parlor, this is the age group, this is the number. So if I ask you how many in the 6 to 10 age group, you will say 30 people. And same if I ask you 11 to 15, you will say 25 people. Okay, so this is a histogram which we see in diagram, and if you were to draw a curve which passes through approximately the middle of these rectangles and then becomes a smooth curve, this is also called as a frequency polygon, or you can say this is the normal curve for this particular histogram. Now, whenever we see a histogram, if the data in the histogram is equally distributed from the center part of the histogram, this is called as normal distribution. If majority of the parameters are on the left or the right, we call it a skewed distribution. So if it is more on the left, like in this case, we call it skewed to the left or left shifted curve. If it is more to the right, we call it right shifted curve. So this is very basics of statistics. So how and where do we use histograms in our CBC machines? So this from example is from a particular model of a 3-part CBC histogram, but across the world, if you were to study and learn any 3-part CBC, it will approximately contain the same parameters, and it will contain 3 histogram figures. One is the RBC plated histogram, and if you carefully observe, the plated histogram is the zoomed out. Okay, so I'm going to use pen here. If you zoom in to this area, this is what is the platelet histogram. So this is one histogram only. Smaller part platelets, bigger one RBC, and we'll go there. And this particular one is the WBC histogram. So we will today discuss these 3 histograms as we go ahead. Okay, in WBC histogram, in a 3-part counter, we know it gives as lymphocytes, the mixed population, and the neutrophils. This is the RBC histogram, this is the platelet histogram. So let's move ahead. In any CBC counter, there are typically 5 parameters which are measured, and all the other reports or the values which you get are derived or calculated values. So anything which is number, for example, WBC count, RBC count, platelet count, or hemoglobin are all directly measured parameters. Okay. In most analyzers, between these two, MCV or hematocrit, one of which is measured and the other is calculated. So if the mean corpuscular volume is measured by one machine, you can calculate the hematocrit by counting by this formula, which is the number of RBCs into MCV by 10. Or if you have the hematocrit which is measured, which is nothing but the packed cell volume, you can The packed cell volume divided by the number of RBC will give you the mean corpuscular volume. So for the others, there are formulas. For example, MCH will be hemoglobin upon RBC. MCHC will be dependent on hemoglobin hematocrit, which is nothing but dependent on the RBC and the MCV. The impedance, RW based impedance, is calculated or derived from the histogram as we go ahead. So we should understand in our machine, these are the measured ones and these are derived or calculated ones. This is important because if these four get altered, okay, the others will be impacted. So when you do calibration or QC, what is most important to measure or to evaluate or calibrate is these five parameters: WBC, RBC, hemoglobin, platelet, and for example, if your machine measures the MCV, then it is the MCV. Now, let's understand the parts of a histogram. As I said, x-axis, this is the x-axis, will measure the parameter of interest. Here the parameter of interest is the cell volume. Can anyone tell me what is FL? Dr. Akash? Femtoliters. Excellent. So on this is the x-axis, that is the volume of the cell. So this is your single parameter histogram which measures the volume. On the y-axis is the number of cells. You see a curve, you see at the line of 2 femtoliters, because we know there is no RBC or platelet which is lower than 2 femtoliters. So this is called a lower discriminator. And upper discriminator is, we know that practically no RBCs are bigger than 250. So this is called the upper discriminator. And then you see this black, which is the baseline. In an ideal world, the histogram should start at the baseline, be smooth, and end at the baseline. Okay, so we'll see this, how this goes. Now, we know there is a fixed discriminator which is called the 2 femtoliter discriminator because there is nothing. Typically, platelets lie between 2 to 30. So this particular discriminator, which we have written as 25 to 30 point, and this dotted line which you see, is also sometimes called the moving threshold. Based on where this curve ends, this line may move a little bit to the right or the left, but generally between 25 to 30. Beyond 30 is where we measure the RBC. So based on the smooth curve, a cutoff is put by the machine and says this area is the platelets, okay, and this area is the RBC. We know RBC are in millions. So 4 to 6 million, for example, which is nothing but 40 to 60 lakhs. Whereas platelet may be 1.5 to 4 lakhs. So assume this is 4 lakhs and this is 4 million. That is why there is a difference in the height over year and year. Because this is 40 lakhs, this is 4 lakhs. Okay, the measurement is area under the curve. That is how you measure the platelets, and this is for the RBCs. That is why the difference in the height. So when you want to see the platelets, we zoom in and we measure the platelets. Okay, so to go more into these histograms, we are now going to go to the actual case studies one by one, and I will discuss with you and ask you questions, and your understanding of histogram will explain that. So what we'll do is we'll start with Dr. Sudeshna. If you could volunteer for this first case study. And what I want to highlight to you is this is a machine strip. It is not very clear. So I have written the values for you here. This patient had a hemoglobin of 8.8, RBC count of 4.48, and an MCV of 65 femtoliters. Can you tell me from this histogram, is it normal histogram? Is it left shifted? Is it right shifted? What is your interpretation from this histogram? Can you tell me your interpretation?
Yes, sir. So hemoglobin is low in this case, and
Very
from the
good.
histogram, and MCV is low, 65 centiliter. Also, we
Excellent.
can see from the RBC histogram, it is shifted to the left.
Okay.
So
Excellent.
it is a microcytic anemia.
Very nice. So based on the low MCV, first you said there is anemia. Okay.
Yes, sir.
Okay. I didn't tell you the age or the sex of this patient, but for any age or sex, 8.8, assume this is an adult female.
Yes,
Okay.
sir.
Where normal hemoglobin would be for an adult female.
So 12 to 14.
Excellent. Above 12. So anything less than 12 in a non-pregnant adult female, this is anemia.
Yes, sir.
Okay. And as you rightly said, MCV is low, 65 milliliters. So now what happens is, it is sometimes difficult if I didn't give you the values to say whether this is left shifted or right shifted. But if I draw this red curve and tell you that this is normal, then it becomes very easy to see that this plot in the patient is left shifted compared to the uh,
Normal.
normal curve. Now,
Yes, sir.
if you want to identify mean corpuscular volume, suppose if I draw a line from this normal curve down, if this is 100 and if this is 50, this line will be approximately at what, Dr. Sudeshna?
Sir,
Approximately.
around 65.
80.
Sorry,
80.
this is for the red normal curve.
Okay,
This would be
sir,
around
around 80
85,
to
90. It
85.
should be
Yes,
80.
normal. Now, if this is 50 and I draw the line over here, sorry, this is not a straight line, this will be around 60, 65 approximately. The machine
yes,
is
sir.
also given you don't need to calculate that. What I was trying to do is, even if you didn't have a normal, you could draw a line here. Even if I didn't give you these values, you could say
Yes,
definitely it is microcytic and lower. And
yes,
plus,
sir.
there is a segment of RBCs which are going lower than 50. Can you see these ones? So
Yes,
this is
sir.
definitely left shifted compared to normal, but it is also useful to have the normal reference curve. Now, how will you have normal reference curve? In 5-part counters, I will show you it is there available in the machine. For 3-part counters, you can always have a normal sample next to you, printed and kept next to you for reporting. Okay.
Yes,
Now,
sir.
Dr. Akash, can you tell me
Yes,
if
sir.
I say the green color plot
Okay,
compared
sir.
to the red or to this gray of this patient, will this be right shifted, normal, or left shifted?
Sir, it is right shifted.
So for the green color plot, I will draw a line to help you to where it is falling. Can you tell me what the MCV would be if the line falls here at this point, approximately?
Sir, 120, 125.
Fine. So if this is 125, this is 150, so this will be around 115, 120, which is fine. It's approximate, which means
Yes,
there
sir.
is
Macrocytic.
macrocytosis, correct?
Macrocytic anemia. Yes, sir.
So this is macrocytosis curve. Now, whether it is anemia or not, if the hemoglobin is low, yes, it is macrocytic anemia.
Yes, macrocytic.
Now, Dr. Sudeshna, we come back to you. We go to the
Yes,
platelet
sir.
histogram.
Yes,
Can you
sir.
tell me, is it starting from the baseline here on the
Yes,
left
sir.
hand side?
Yes, sir.
Yes. On the right hand side, is it reaching the baseline?
No, sir.
It is not. Is the RBC curve reaching the baseline over here?
Yes, yes, sir.
It is not touching the baseline, the RBC curve.
Okay, okay,
Correct?
sir. Yes,
Now,
sir.
can you see this flag called as PU over here?
Yes,
It means platelet upper axis. It is telling you, please look at the graph.
yes,
In the platelet histogram, the upper discriminator, I am not touching the baseline. So it gave you a flag of PU. Now
okay.
every machine will have different codes. It may give you PL, PH. PU means upper, PL means lower. But the machine is telling you, I am not confident. Please look at the curve. Okay. Here, if you were to carefully zoom in, you would have seen it is not really touching the baseline. So if I go back to my original histogram, this is where it should go. Here it is slightly above. Okay. So what we were trying to see is it touching the baseline or it is not touching the baseline? Because this has a importance which we will discuss as we go ahead. Okay.
So not touching the baseline.
It is not touching the baseline. So that means either there are, we will discuss this in the next case as we go ahead. Okay. Now I am going to move to Dr. Akash again.
Yes, yes, sir.
Dr. Akash, can you interpret this histogram over here, this one?
Uh,
What is happening?
Sir, it is shifted to left side.
Okay. Anything unusual about this histogram? I am
Sir,
helping you
there is
out.
a sir,
There
there
are
is a dip. There is a dip.
dip. Okay. So compared to the previous histogram, where here I saw only one peak. Okay.
Okay, yes, sir.
Now you see this histogram. One peak or two peak?
Two.
Two peaks, sir.
Two peaks. So that means there are two RBC population. I don't even need to look at the smear. I can tell you there are two RBC population over here.
Yes, sir.
Okay. So what is this picture? There's a dimorphic picture. Now can you tell me what kind of dimorphic is it? Is it micro and macro, normal macro? Can you give me an idea?
So micro.
So this is 50. So if I drop the line here, this is coming close to 60. So this is definitely micro. If I
Micro, yes,
drop a
sir.
line here, it might come to close to 90 or 95.
That is normal, sir.
Normal. And some of these appear to be macrocytes. So it appears as majority are what? Micro or normal? Majority.
Micro.
Micro.
Micro,
Micros.
sir. Micro.
Micros.
If you saw the MCV alone without the histogram, would you have made out that this is dimorphic?
No, sir.
No, sir.
No.
No.
So which value in the histogram would have made you suspect that there is dimorphic? Which value in these four parameters?
RDW, sir.
RDW, sir.
RDW,
Excellent.
sir.
So Dr. Akash, what is the full form of RDW?
Sir, red cell distribution with
Width. So very good. So any histogram, when you draw, and I'm drawing this, essentially the base of the triangle. So this is the curve, the base of the triangle. In different instrument, it is measured at different time. Like for example, it is measured at 2/3 of the histogram. That is where the measurement point is. But what I mean to say is the base of the triangle defines. So if in a normal histogram, I'm just drawing, if this is the base, if the base becomes widened, then we say RDW is increased. Normal RDW is how much? Dr. Kezia?
11 to
11.
14.
11 to 14, sir. 11 to 14.
Excellent. Okay.
and
So
sir
if it's 11 to
standard
14, RDW
density.
35 is very wide. Sometimes
Yes, sir.
when there is a bimodal peak, the machine will not be able to measure the RDW. It will give you dash dash dash. Okay, many times this dash 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 comes, which is also a clue
Yes.
that machine could not measure the RDW. Please go back and see the histogram. Do not miss it. Okay. So here I can tell you without the slide, this is a combination of microcytic and normal cells.
Microcytic and
So
normal
what is
cells.
the cause of this dual peak in this patient? Dr. Akash, I'm coming back to you.
All right, sir.
Hemoglobin 10.4, two populations. How can a person get two RBC populations in the blood? Dr. Kezia?
Sir, one post transfusion, sir. Post
Fine.
transfusion or might be an iron deficiency anemia on treatment, sir.
Excellent. So, Dr. Kezia, if I can ask you, when we transfuse blood, 1 pint of blood in an adult male or female, by how much will the hemoglobin increase?
Sir,
Approximately.
so one almost like
1 to 1.5 grams. Excellent. So, if this patient has a hemoglobin of 10.4, we assume if this was transfusion, the pre-transfusion would be 9 or 9.4. And generally, nobody will transfuse at 9. Correct?
yes,
And
yes, sir.
general
Yeah.
transfusion limits will be around 7 unless there's any other indication. At 7, we are not going to give 2 or 3 bags to this patient to make it 10.4. Very rare. Okay?
Right.
So this is unlikely. So we go to your second point that this is likely that this patient was iron deficient and this is transfused. So Dr. Kezia, we go ahead. Now, this is the same patient actually when we go down. What is the difference
Yes.
between the histogram above and below? Both are showing two peaks.
Um, so more of macrocyte, normocytic pop.
Excellent. This is around 90 and then this is around 60 again.
60.
60 hours.
Okay. Roughly. I'm just
Yes,
giving rough figures. Maybe it is 95 and 65. I don't know. Okay.
yes, sir.
So, as you said, more of normal, less of micro. So, if this patient was given hematinics, this patient's hemoglobin went from 10.4 to 13.2 in a couple of months. What is the lifespan of RBCs?
120 days.
120 days, sir.
3
120 days.
months, approximately 3 to 4 months.
Yes,
So,
sir.
what
Yes,
happens is once the microcytic RBC is formed, it is going to be in your body for some time. Okay.
yes,
So,
sir.
actually, all the three plots which I showed you, starting from the first one, are of the same patient. This patient had a hemoglobin of 8, then was given iron and therapy hematinics. Normal cells started coming. So, you had some normal. But when we give hematinic therapy, what is the response in the bone marrow?
Atrial hyperplasia.
Hyperplasia. What will come into the peripheral blood?
Reticulocytes.
And they are big in size. So can you see
Yes,
these are polychromatic reticulocytes which you see on the smear or the macrocytic cells which you are now seeing. Okay. And then there are some normal population. So here at this time there was a little, if you do the MCV, it would be maybe 100 for this peak. But as time passed by, the number of macrocytes would have become lesser because now the hemoglobin has become normal, 13.2. You have more of normal population, less of micro, and when these will die, you will have normal population. So when you start a patient on iron therapy, like we saw in these two patients, okay, what has happened is compared to normal, there was more left shift, less normal, and compared to reference of normal, now there is more normal and less this, less of the microcytic hypochromic population. Everything started improving. Okay, hemoglobin improved, MCV improved. See, from 65 it went to 80, then it went to 82. MCH from 23.8 became 25. But what worsened is the RDW
DW.
because there is more variation in size. Earlier there were only microcytic. Now there is microcytic plus normal cells also coming. Okay. So worsening of RDW does not mean patient is not responding. It actually means patient is responding, and hence there is variation of size, which we can see from the base of the triangle, which was so wide. Okay. So that is what RDW tells you very simply. So simply looking at the histogram and one value of hemoglobin, we could have predicted this is a patient of iron deficiency anemia on hematinic therapy, and we are seeing bimodal peaks. Now imagine as a pathologist, when you put this out on the report, the confidence of your clinician will be sky high. Okay, that is what we want. Otherwise, every time you see this picture of 10.480, you write microcytic hypochromic, advise iron studies. Okay. Every report we are writing advise iron studies, and we forget there is a cost to the iron studies. You are pricking the patient again. Okay, but if you pick up the phone, ask your clinician, is this patient hematinics, or speak to your patient, they will confirm to you, yes, I am taking oral iron therapy. Okay, so you can mention that in your report. That is what we want. We want you to think as a physician first, pathologist second, but please interpret the histograms. Okay. Now, case study 3, we will move to Dr. Shubham. Okay, this is a curve where it was similar to the first case, where this mark RL is coming. Can you tell me what RL could be? It is a RBC flag. By any chance? So RBC, lower discriminator. It is the same as the PU flag. When you interpret platelet, it will give you PU flag, platelet upper discriminator. In RBC, it will give you RBC lower discriminator. So, but Shubham, can you tell me what are the causes when we have a curve which does not start at the baseline? Anything that comes to line. Why is it not touching the baseline? What would be the causes for RBCs?
So for RBCs, it may be according to the size of the RBCs if the other cells are present in the blood.
Like,
Accordingly, fragmented RBCs can be there, or it can be like the nucleated RBCs.
so you are saying small RBCs and fragmented RBCs.
Yes,
Okay.
there's more. Yes, yes.
So now if you say RU curve, what would that be? RBC upper.
Upper discriminator.
So if you see the curve, look at the histogram. Immediately you see lower part it is touching the baseline, no problem. But at upper part it is even crossing the flag. That means what is the possibility?
So it may be NRBCs present in the.
Hmm. Anything else? It tells you that there are big size RBCs. Yeah.
Nucleated
That
RBCs.
is, yeah, that is one. Or we will discuss as we go along. So here, two options. Problem can be from the platelet side, from this side, or problem can be from this side. Okay. This problem may be because of giant platelets, or microerythrocytes, or platelet lumps. Okay. In the upper side could be either agglutination, lumps of RBCs, or as you rightly said, NRBCs. Okay, all these things have to be kept in mind. So what I'm showing you is very diagrammatic approach. I'll show you the cases. What I'm trying to explain to you, the name of the flags, they are individual for your particular machine and model. Please understand it. They are just telling you, please look at the histogram. And we keep avoiding that. Okay. So you can see the histogram, you know that why this is flagged. So then you know what to look into your smear. If you don't see the histogram, how will you know what I have to find? Okay. There may be 10 NRBCs, but you have missed it. But had you seen the flag, you would have looked for it. Had you seen the histogram, you would have definitely screened it. Okay. So this also becomes your smear review criteria. Abnormal histogram, I want to see my smear. Okay. So we move to Dr. Harini. This is the platelet curve. What kind of a flag would have come with this if it does not end at the baseline? What would have been the name here? PL, PU, RL, RU?
PU, sir.
PU, excellent. So because we are related to platelet, this would have been platelet upper discriminator not meeting the baseline. What would be the causes?
It could be either fragmented RBC, platelet clumps, microerythrocytes.
So same causes which were for there for the RL flag. Okay, platelet clumps, clotted sample, giant platelets, microerythrocytes, erythroid fragments, because both are the same histograms. The machine does not know that this is platelet or RBC. It is measuring only particles. Based on the size and the curve, it says smaller one platelets, larger one RBCs. But if there is a confusion for the machine when there are giant platelets or clumps or small RBCs, there's an overlap in size. Machine does not know how to count it. So we need to see the flag. So what I do is whenever I see this histogram, first thing I see, is there microcytosis? If MCV is normal, unlikely it is an RBC issue. Then I know it's a platelet issue. So I'm already screening my smear for clumps. If platelet count is normal and there is microcytosis, then I know more likely RBC issue.
RBC.
Okay. Then I'm looking for microcytosis. If there is no microcytosis, I am looking for RBC fragments. Okay. If the platelet count is low, I am looking for platelet clumps. So based on the findings on your RBCs, platelet values, and these curves, we can then start screening our smears. Okay. Any question on this? So in this patient, this was the peripheral smear. There were multiple large platelet clumps, which caused this kind of flag. There were giant platelets clumps, there was a zigzag in the appearance, and there were clumps. Dr. Nina or Dr. Bhave, if you have any comments on any of the cases, please feel free to add in or pitch in anytime.
I just want to add, Dr. Kunal,
Yes,
the
ma'am.
way you rightly said, with histogram, they can analyze anything. Even early deficiencies of iron, just slightly shift to the left or early macrocytosis, if they are vigilant, then the MCV and many parameters are normal, but one or two parameters like MCH or RBC count may be abnormal, and they can, if just they concentrate and develop curiosity, they can analyze.
Very true. So what ma'am was saying, if you keep focusing on histograms, you will start picking up subtle clues of microcytosis. You will start seeing a little higher RDW, say a value of 16, 17 with the MCV of 78, which you may ignore. But this could be an early iron deficiency anemia starting in this patient. Okay, and becomes very clinically relevant. And unfortunately, in our country, across the social classes, whether they are poor, middle class, or rich, iron deficiency anemia is extremely common in both. So we have a very important role to in identifying this and helping our patients. So, any questions on the basics of RBC platelet histograms? Because I've just done basics. We'll go to other case studies. But any questions from any of you doctors, participants? Great. So we'll move to a WBC histogram. Now you will say, why am I teaching WBC histogram on a 3-part counter? All of majority people use 5-part counters when WBC histogram really doesn't come. And we have WBC scattergrams there. Now scattergrams of WBC is in another class by itself. So I'll not go there. But remember, everything came from the same concept. So it's important to understand how these histograms were defined. Again, here we measure WBCs. What happens is when the sample is analyzed by the machine, when they are measuring WBC, the RBCs are lysed. So if you see here also we are measuring femtoliters only. Here also we are measuring volume. Here also the volume is ranging from, say, starting from 2 and moving to 250. This is the same for RBCs. So they don't interfere because you lyse the RBCs and what is left behind is the WBCs. Again, based on size, they have divided. Smaller ones are lymphocytes, middle ones is mixed, which is EO monobaso, and the larger one here are the neutrophils.
Neutrophils.
Again, if you see, curve starts at the baseline, ends at the baseline, starts at the baseline, ends at the baseline, start approximately. I'm not saying it is touching, but it's a smooth curve. Okay, it's not as if the curve is starting here and interfering and then forming a population. Okay, so that's not happening. Then we go to the next one. So the question is, when we see a smear, the monocyte and the neutrophil look almost the same size. Okay, but here I am saying monocytes, eosinophils are actually smaller. Why does this happen? When you have the actual cell morphology in the smear, your monocytes may be actually bigger than neutrophils. Eosinophils and neutrophils are similar size. But after we add the lysing reagent for lysing the RBCs, this gets impacted. Hence, the impact on the monocytes, eosinophils is slightly more. They end up with similar size, whereas the impact on the neutrophils is lesser. They remain to be larger size. Okay, so that is the challenge when we are seeing these kind of cases. So we should know why is monocytes falling in mixed, whereas why are neutrophils bigger? It is because of the impact on lysis. Okay, so I will move to the next slide. Now, in this particular machine model, okay, this particular machine model, you will see this particular name of the flags. Okay, population 1 is also called F1, population 2 is called F2, population 3 is called F3. Okay, that's just a name given, it doesn't matter, ignore the name. But you will see lower discriminator, then they have labeled T1, T2, upper discriminator.
Upper discriminator.
Okay, T1 discriminates between lymphocyte and mixed, T2 between mixed and upper
Neutrophils.
neutrophils, and the upper discriminator. So the machine will give some flags. If it gives a T1 flag, problem is somewhere in this region. If it gives a T2 flag, problem is here. Lower discriminator we know, upper discriminator we know. So based on the flag, we can learn and go back to the histogram, or we can ourselves see the histogram and go and identify what it is. So for example, if there's a patient with infection, high counts, neutrophilia, this peak will be very high. So you know there is neutrophilia. I don't even need to see the number. Whereas here, the lymphocyte peak is very high. Here the mixed peak is high. I don't know, eosinophilia, monocytosis, I will have to see the smear. This was the case of eosinophilia, but that's okay. Okay. So this is what we see. So compared to normal, if I see this particular histogram, you will see there is potential mixing at these two levels. Okay. It is not showing a smooth curve. Okay. So the machine sometimes gives a T1, T2 flag, or we know in 3-point it sometimes does not give a differential count. It says I can't make out. It will give you only lymphocyte percentage, but will not give you the other percentage, and hence you start seeing a manual differential count. Okay, so we are going to discuss this particular case. Okay, Dr. Swarupa,
Sir.
can you tell me, there is a flag given by the machine called as WL, and I have
Yes,
already highlighted. So what this WL can mean?
WBC lower discriminator, sir.
Excellent. And you can see that the lymphocyte histogram, instead of going down here, it is ending at over here only.
Yes,
So
sir.
what could be the reason, potential causes?
Sir, any lice resistant RBCs, sir,
Excellent.
which are seen in newborns or in severe liver dysfunctions, or any cold agglutinations, any
Okay.
platelet clumps, and
Yes.
any NRBCs, nucleated RBCs.
Excellent. So anything which is the size of a lymphocyte, okay, is mixing with the small lymphocyte over here. One. And as you said, this could be platelet lumps. Okay, you could be NRBCs. And if RBCs don't lyse or form clumps and do not lyse, they could interfere with lymphocytes. So all the causes you listed were correct. Okay, high osmotic resistant lymphocytes. These could be the different causes. Okay. Now I will go ahead and we will discuss about moving from 3-part to 5-part analyzers. Okay. Now, when we go and discuss, when we go into 5-part analyzers, remember that 5-part analyzer, the RBC and platelet histogram principles remain exactly the same. There is no difference between the principle of histograms. Okay. So, what I'm going to show you is a normal CBC first. Okay, you see the RBC histogram, you see the platelet histogram. There is no difference. The colors are different. Here there is dark blue and light blue, and I come back to this. And the RBC's flags will be given, which the machine interprets from the histogram, which we have only taught the machine and given fixed ideas. What today we call artificial intelligence. Okay,
Yes.
the machine, if it is left shifted, it will say microcytosis, then it will say maybe iron deficiency anemia. Okay, we have taught the machine when you see left shifted flag, but we humans who have taught the machine are not ourselves interpreting that. We have become dependent on the machine. If the machine says left shift, we say left shift. That should not be the case. We should understand what this is. Okay. Then we are going to go into this histogram, and now I'm going to hide something which is the units. Okay. Now, one by one, Dr. Akash, you know the units of WBCs?
Sir, microliter.
How much is normal? This is given
Uh,
5.24. What does this mean?
4,000
524.
4,000 to 10,000 per microliter.
But here it is written 5.24.
So
So what
it
would
is
be the
normal,
count
sir.
over here?
It is normal, sir.
But what is it? Is it 524? 5 cells per microliter, 500, 5,000, 50,000? What is it?
Sir, 5,000.
Yeah. So clue was here 10 is to 3. Okay, 5.24, 5,240 into 10 is to 3 per microliter. Okay.
Yes, sir.
Now, Dr. Sudeshna, hemoglobin units,
So gram per DL
gram per.
deciliter.
Okay. Dr. Kezia, MCV units,
MC femtoliter, sir.
and Dr.
Femtol.
Swarupa, picogram is a unit for.
Sir, MCH, sir.
Excellent. So all of you have read well. Okay. So sometimes we forget the units or the conversions. We should not forget. We should remember them, and we should understand what are these units. This is just given to you for reference, and this is going back to again early days where you recognize unit. What is milli? What is micro? What is nano? What is pico? Okay, nano 9 everybody knows. Pico is
Yes, sir.
12. Femto F for 15. So that is femtograms or femtoliters, depending upon what you're measuring. One should understand the units. You could take help of the scale. There is no harm of keeping the scale next to you. As said, we are looking at really small size particles. So micro, pico, and femto. And we should also understand the relation between micro and a liter. Because what happens is in different labs, the units are given differently. So, Dr. Harini, I would like you to request to tell me, I have matched certain parameters here. For example, WC on the left is also written on the right, but with different units. Tell me which is the wrong pair. Okay. So, WBC here is 4,000 to 10 to 6 per liter. Here is 4 into 10 to 3 per microliter. Is this correct? Are both the same or they are different?
4,000 microliter. Left is wrong, sir. 4,000. The right side is showing 4 into 10 to the power cube per microliter. That means 4,000 per microliter. And 4,000 10 to the power 6 ml. Sir, this left one is wrong, sir. It should have been micro. It should have been ml.
It should have been.
Milliliter.
Okay, so we'll go back to the units. So that is why I kept the scale. So if you move from micro is 10 is to minus 6 of a liter. Okay. So
Yes, sir.
1 liter has 10 is to 6 microliters. Okay. I think something happened. Sorry, I'm going to share my class again. somebody has put on the whiteboard. That's why this happened. Okay, close whiteboard. Okay, 1 second. I want to share the presentation. Can you see it?
No, sir.
No, sir.
Yes, sir.
Yes, sir.
Yes.
Okay, so normally 1 liter is equal to 10 raised to 6 microliters. Okay, so this 1 liter 10 to 6 is same because it was microliters converted. 4 into 10 to 3 is 4,000, which you did correct. So anytime there is a difference from liter to microliter, there will be 10 to 6 which will be coming. Okay, so either there is 4,000 per microliter, it can be written at 4 into 10 to 3 per microliter, which is the same thing. So I can write 4,000. Okay, or I can write 4 into 10 to 3, it is the same meaning. Here, what did I do? I also converted from microliters to liters. In 1 liter, there is 10 to 6 microliters. Okay, so same way now RBC 4.48 into 10 to 12 per liter or 4.48 into 10 to 6 per microliter. So, what do you think? Is this correct?
Correct, sir.
Excellent. Because the unit difference is only this.
Unit.
Okay. Now we go to the next one. Correct?
RBCs.
4 into 10 to 12 per
Yes,
liter.
Yes, sir.
Yes. Yes, sir.
Yes, sir. Yes, sir.
Platelets.
Yes, sir.
No, sir.
No, sir.
No, sir.
Okay.
Should be
Which
10
do you
to the
think is
power of
wrong?
6 per microliter.
Okay. So either I can have 235 into 10 to 6, but now if you
10 to
think
6.
what is normal platelet count?
1.5.
150 to 4,
1.5
If
4
this was the
100.
right one, 2,35,000, because I would have added 3 zeros, right? 2, 3,
Yes.
5. So if this was
Zero.
2,35,000, on the left hand side, what would have been the units? What is wrong?
10 to the power
10
of
power 9.
Hours.
Excellent. So this would have been 10 is to power 9.
9.
So from 3, you have to go to 9 per liter. Now here it is 25,000 per microliter or 25 to 10 to 3. So again, the difference is 10 is to 9 per liter.
6.
Why did I show this? Because in different instruments, in different labs, in different parts of the world, you have different units and we get very confused. So do not forget units. Okay, this is the very basic things. Please focus on the units given in your report. And when we telephonically tell the report, we say, "Arey, platelet 25. What? 25,000? 25 to 10 to 3. Sometimes urgent report goes 5.24. The clinician might interpret as 524 and leukopenia. Okay, so we have to say it is 5.24, no, 5240 or 5240, whichever way. But either you give the whole report. And in today's day of WhatsApp, it is safer to give the image of the report or at least a screenshot. So there is no misinterpretation of your report. Okay, so now we are going to go to this histogram. Now this is a 5-part counter. Okay, it is giving you some help and clues. Okay, the values are given here. So randomly I'll go to Dr. Shubham. Okay, can you interpret this patient? 50-year-old female patient, hemoglobin 11, MCV 78.7, platelet 65. If you saw only these values, what would you tell me?
It would go to like iron deficiency, hemoglobin is less, so anemia would be suspect, and MCV is less than 80, 78.7 into 8 can be a microcytic or a little normal with few microcytes, a normochromic picture.
Okay, excellent. So you are
And
thinking of a microcytic hypochromic anemia. What advice would you write on your smear?
so after the treatment protocol, we can redo the rest after like the therapy,
Sorry,
therapeutic trial.
I didn't get you. Repeat. You can advise for a repeat. You said.
Yes, sir. A repeat, and we can repeat the test after therapeutic trial of the iron.
Repeat trial. Okay. Now, anything which is missing in this report on
So
the machine?
the RDW, SD, and CV are not there.
So, what do you think? Why it is not come?
So
Wide.
the width of the histogram couldn't be analyzed according to the analyzer.
So, I have zoomed in the histogram for you.
Yes,
The
sir.
dark blue is the reference for normal. Now,
Yes.
in many analyzers, this is a setting. So, in some machines, you have to ask your engineer to put the setting on. They right click it and the setting comes on. So in every patient, you will see this dark blue curve, which is reference of normal,
Yes, sir.
and the light blue is the patient. Now, what do you get to know?
So it is showing a bimodal peak, so maybe a dimorphic picture.
Yeah, again dimorphic because of
So because the two peaks are
Iron
so it's
deficiency
a bimodal peak.
treatment.
now you have to tell me only one thing in this case. You have the hemoglobin.
Hematinics,
Iron deficiency.
hematinics, any
Yes, so
treatment,
exactly the
hematinics.
same case which we discussed on the three-part counter. The same logic and principle applies here. But what happens is we are so geared to only look at these values and start making our interpretations. We didn't even look at the histogram, we didn't look at the RW.
Yes, sir.
Okay, that is what I wanted to bring to your light. If you saw the histogram, you would have said dimorphic population, micro and normo, very mild anemia. I want to ask the patient the history of hematinic therapy.
Yes, sir.
Okay, and I would not advise iron studies or ferritin levels on this patient without asking the history. That is what I want to bring to attention. So, and you look at this. Now your RBC flags, the machine is already giving you
Yes.
abnormal distribution because RDW didn't come. And you see, this is the base of the normal population,
Yes,
and
sir.
this is the base of the patient population. Very wide. It is telling you hypochromia because MCH is low. It is telling you anemia because hemoglobin is low.
Yes, sir.
Everything which you and I can interpret, correct? So this is everything is coming from the histogram. Now we go ahead. This patient's previous histogram, I showed you the 11 gram was this one. Left shifted, normal or right shifted?
Left shifted.
Left shift, sir.
Left
What is the
shift, sir.
RDWC? RDW was 19.
19.3.
19.3.
And as this patient got hematinic therapy, what happened to the RDW? It sort of
Both
on theoretically
microcytic and
worsened.
normocytic.
Okay, everything has improved. RBC number going up, hemoglobin going up, MCV has gone up, platelet has become normal from high. Why? Anybody?
Plate.
Is this normal expected? Platelet was high earlier and become normal now.
The earlier microcytic population was predominant, so maybe it was counted in the platelet.
That is one option. Second,
And increased plate, whenever there is increased number of RBC production, simultaneously there is increased production of platelets because of the precursors from the
so
stem
when the
cell.
marrow is stimulated, there may be a reactive thrombocytosis in iron
Yes,
deficiency
sir.
anemia.
Yes,
And
sir.
sometimes when you
Yes.
have severe microcytosis, it may interfere with your platelet count. Just because platelet count is high, do not leave it alone. You need to check your smear and check whether it is matching. Check your histogram. Sometimes you can clearly see RBCs going to the platelet, maybe false high platelet count of 7-8 lakhs. Okay, so you have to always check. So both causes. So here what happened in this case was reactive thrombocytosis, which with therapy for iron and for it given to this patient, the platelet count settled. Now this same patient initially, if you see 18th of April, in 1 month, initially the marrow responded very well, jumped from 8.4 to 11. Lot of capacity in the marrow to regenerate. Now this is after another few days, hemoglobin has gone up by 0.9. Again, see the difference in the histogram. So Dr. Harini, can you tell me what's the difference between these two histograms? This is the month of May, this is the month of June. What has changed?
Sir, here in the second one, microcytic curve was more, and the
Correct.
second one, the normocytic curve is
Excellent.
like more.
So as hematinic therapy is happening, exactly what I showed in three part. So any difference between the concept of a three part, five part? Nothing.
Mm.
No,
Same,
sir.
similar scenario, but we are focusing only on the values and the flags and not on the histogram. That is the take home lesson. Okay. So Dr. Sarupa, we discussed
Sir,
this case.
yes, sir.
So
Sir,
I wanted to interpret this patient's values and the histogram.
so the WBC level is normal,
Excellent.
hemoglobin level is normal, hematocrit is normal, but the MCV count has elevated, like mild elevation,
Excellent.
so 103. And apart from that, the platelet has reduced,
Okay.
mild reduction. So based upon the histograms, there is shift towards the right,
Okay.
which indicates that there is few population of macrocytes.
Okay.
And
What would be
in
the case? What advice would you give to this patient?
sir, I would suggest to look for any vitamin B12 or folic acid deficiencies, or any thyroid or any drug usages.
So you will advise vitamin B12 and folate levels
No,
for
sir,
this
because
patient?
there's no anemia.
Exactly. You
No
know the cost
anemia.
of the test?
Yes, sir, it's high, sir. It's 1200.
Yeah, very expensive, right?
Yes, sir.
So you have to be careful. We would not
So we'll
advise
just
to
ask,
outside to do that test.
we'll ask the
Yeah,
clinical history, sir, if the patient is
excellent.
on any drug therapy.
Excellent. So drug therapy, as you said, thyroid, liver function test, we need to know all that. This patient was a patient on hydroxyurea therapy, okay, and had slight macrocytosis. If I remember correctly, this was the same patient and had borderline thrombocytopenia. So this was a drug causing macrocytosis. Okay.
Okay,
There are
sir.
a lot of different drugs which can cause. What was important, as you highlighted, you saw the whole information. There was no
Yes,
anemia.
sir. Yes, sir.
But if I said the hemoglobin was 8.9 and the RDW was 18 or 20 or 22, then that is likely anemia, megaloblastic or macrocytic anemia, and you look at the causes.
Yes,
Here,
sir.
when you have macrocytosis with normal RDW, think
Yes, sir.
of first thing is drugs. Okay.
Yes, sir. Yes, sir.
Alcohol, drug-induced changes, and all those kind of things need to be discussed or
Also, the
be
platelet
realized.
level hasn't touched the baseline, sir, in the platelet histogram.
Excellent. So you need to see the smear.
Smear.
Are there
Yes,
giant
sir. Is
platelets
there
or
any
are there
giant
small
platelets?
clumps?
Yes, sir.
Okay. So that is
Yes, sir.
where
Platelet clumps.
a star has come over here. It is telling me platelet abnormal distribution and thrombocytopenia. So it is telling me this star, please look at me. Please look at myself, look at the smear. Okay. So we look at the smear and we identify that in this case, there were few giant platelets, there were no clumps. Okay,
Yes, sir.
we go to the next case. So, Dr. Kezia,
Yes, sir.
no histograms, just the CBC.
Okay.
Please interpret. Patient is a 21-year-old female.
Okay, sir. WBC count is within normal limits, sir. RBC is also within normal. Anemia is there. Hemoglobin levels is decreased. So the CV is towards the lower side. Microcytic picture, sir. The MCH is also
Yes.
hypochromic. Microcytic hypochromic, sir. The microcytic hypochromic anemia, sir.
Okay, so you have a picture of microcytic hypochromic anemia. What are the potential causes?
Sir, one iron deficiency anemia,
Okay.
thalassemia,
So what do you think is
sideroblastic
there?
anemia, sir.
What do you think this patient is having?
Sir, iron
Is there any
deficiency.
parameter which can help you differentiate between iron deficiency anemia and thalassemia trait?
Sir, MC.
Will be low in both. This is the peripheral smear. Any particular cell type which you are seeing?
RDW, sir.
Excellent.
RW.
So RW normally is say 11 to 14 up to 15 we see variation. For the severity of the low MCV, the RW is almost close to normal.
Yes, sir.
Okay. For the degree of low
Targets.
MCV, RBC count in a female patient is slightly on the higher side. We are seeing lot of these targets.
Target cells,
In
teardrop cells,
addition
target
to the
cells.
microhypo, elliptocytes,
Yes, sir.
irregularly contracted RBCs, and you're seeing a lot of target cells.
Yes, sir.
Okay. So what is potential thing cause in this patient?
Beta thalassemia trait.
Beta thalassemia trait.
Okay. So you can do various indices.
Yes.
We know Mendel's index. In our lab, we use the Segal index, which is nothing but the MCV square by RBC. With the current day analyzers, we have a possibility of incorporating these formulas into your machine. You could use RW index, Mendel's index, the way you want, Shine and Lal index, whatever you want. Idea is use something. Try and incorporate it into your machine analyzer. So in this case, if we calculate the value, MCV into MCV divided by RBC, the value is 871. The cutoff for this formula is less than 972, suggestive of beta thal trait. This is the published paper. As I said, we have put this into our analyzer, this formula. So what it does is, the moment there is a thal trait positive, we get a flag over here, suspect BTT. So the staff or the technician itself is aware that we need to screen for thalassemia trait. And when the printout comes to you, the photograph comes to you, you can look at that. So I will go to Dr. Swarupa.
Sir,
Can you interpret this case?
so there's a mild elevation in WBC count, sir, levels.
Yes.
And HP has hemoglobin levels has reduced, so that there is anemia, along
Yes.
with decrease in MCV.
Excellent.
And there's a slight decrease in MCH level as well.
Yes.
And there is increase in red cell distribution with
Okay. Histogram, anything?
histogram. There is left shift, sir. So microcytic hypochromic picture.
Again, similar picture. So what are we dealing with?
So again, we have to differentiate between iron deficiency anemia and beta thalassemia trait.
Okay. So here the RW is high.
Yes, sir. RDW is relatively high.
So more likely to be iron deficiency?
Yes, sir.
Okay. Anyone else? So generally, when you have an iron deficiency anemia, you see this 5-part analyzer is giving you some clues over here. It is saying this parameter is in the upper limit of normal, this parameter is in the lower limit of normal, green limit is normal, because you have inserted normal range. Hemoglobin, MCV, MCH are on the lower side, whereas RBC is in the opposite side. Okay. RBC count 5.57. This is again a female patient.
Yes,
Very
sir.
high, right?
High, sir.
For the degree of low MCV, 56.9, severely microcytic. RW is only mildly elevated. So what could this be? Anyone?
So
Combined.
the MCV is affecting
Excellent.
the
Combined.
RDWCV.
So this is a combination of
Combination
thaltrate with iron
and
deficiency
iron
anemia.
deficiency anemia.
So remember, just looking at one parameter does not help you. Here we need to look at the smear. This patient had very low MCV. In practice, if you see an MCV of 56 or below, or an MCH of 18 or below, it's almost always the patient will have iron deficiency anemia. And if the RBC count is high, you suspect a thal trait. Now, what are the tests you will advise this patient? HPLC to measure what levels?
HbA2 level.
Excellent. And what other test? Because if I need to prove as a clinician or a hematologist, if I need to start ferritin, iron treatment, I need to do ferritin levels and or iron studies, right? I need to
Yes,
see
sir.
whether my stores are low. So iron stores were low. Now HbA2 level came as 3.4. What is the cutoff to call thalassemia trait?
3.5.
So some machines have 3.6 and above, some have 3.8 and above. So does it matter now? HbA2 came at 3.4. Can I say this is not thal trait? So all of us advise this test, but remember, in severe iron deficiency anemia, HbA2 levels will be falsely low. So we modify the advice a little bit and we say, please do iron studies and ferritin level and HPLC testing to be done after hematinic therapy and improvement of hemoglobin. So that unless the patient is pregnant and you don't have a choice and to wait, we would advise in a non-pregnant female to do it after hematinic therapy. Suppose the patient has already done it. And in an iron deficient patient, if you see HbA2 level of above 3, always, even if it is 3, 3.2, always advise repeat HPLC after hemoglobin normalizes after hematinic therapy. We have seen patients where we have falsely labeled them as not thal trait and they turned out to be thal trait later just because after iron therapy it was diagnosed. Obviously, family history is useful. So this patient was concomitant iron deficient. So Dr. Harini, we go to this case study 10. There are two cases. You can interpret either one, both are similar.
Hemoglobin in case 1 it is 7.3
So low anemia, okay.
And in case 2 also it is 7.9.
So interpret only case 1. Ignore the case 2 right now. It's okay. It's similar.
Hematocrit, it is 8.2.
Okay.
And MCV 97.6, it is normal. And MCH 86.
For an adult, male or female, generally up to 94 or 95 normal, so slightly elevated, okay? MCH 86, MCHC 89, and WBC count 8,000. So what do you think this patient has?
Patient is anemia and MCV is elevated and DW is also increased.
Have you ever seen such a high MCH?
Oh, sir, it is abnormally too high, sir, MCH.
Is there any problem with this hematocrit and the hemoglobin? What is the normal relation?
Hemoglobin into 3 equal to hematocrit.
What is happening?
Rule of
7.3 into
There
3
is
would be?
violation of rule of 3.
21.
Yeah. So there's a hemoglobin hematocrit mismatch.
Yes, sir.
Look at
Yes, sir.
RBC count.
Not reduced.
That also has a rule of 3, na, generally.
Yes, sir.
Approximately. There is a mismatch there also.
It's sitting into 3.
Very low RBC count, very low hematocrit,
Yes, sir.
abnormally high. This
MCH.
is not viable.
Let's see.
This can never happen. Okay? This high MCHC
Yes.
can never happen. So now anyone?
RBC agglutination.
Excellent.
Sir, any agglutination, sir?
Excellent. So whenever you see an MCHC above 36, typically above 40, and you see a hemoglobin hematocrit mismatch, this is the problem. Okay, what is happening is instead of counting one RBC, it is counting 10 RBCs which are clumped together. It counts this as one RBC. So the number of RBCs become less. So hematocrit becomes low. But hemoglobin measurement is not a problem because you're going to lyse the RBCs, whether they are single or they are clumped. So hemoglobin is correct. But the indices become wrong. WBC count is okay, platelet count is okay, but the RBC indices are not measurable in a correct fashion. So what can we do in agglutination?
So we can incubate the sample
Take
and
the
rename
CR
the
and
sample
C8 1 and you can incubate the sample at
37 degrees centigrade.
Room
excellent.
temperature 37.
So we
Reran the
incubated the
sample room.
sample at 37 degrees for 1 hour and we reran the sample. In patient 1, hematocrit improved to 22.6, MCV was similar, MCHC became almost normal. In patient 2, even after incubating, MCHC did not become normal. The hematocrit increased a little bit, but still there was a violation. Why? In case 1, 10A, after warming, agglutination went away. 10B, it does not go away completely. This happens. That's why I showed 2 cases. So I will not go into details of co-adherent disease, but whenever you have co-adherent disease, you have to look at the history. Anyone knows the causes of co-adherent disease, common causes? Any infective cause?
Mycoplasma pneumonia.
So this first patient had a infection, pneumonia. We advised for mycoplasma pneumonia based on the perishable blood, and the mycoplasma pneumonia came positive. Patient already had pneumonia, but purely on the CBC we advised this, and the treatment was started. Case 2 actually had a lymphoproliferative disorder because we did not have any infections, and we asked them that we should do a immunofixation study. Protein network was positive, M band was present. There was an IgM kappa type of M band, which we know is also associated with a diagnosis of lymphoplasmacytic lymphoma. So, cold adherent patients may be due to some paraproteinemia or some infections. So, we should look at the common causes and we investigate. Okay. So, these are just 2 examples to show how looking only at the CBC and its indices, you could pick up cold adherent disease, confirm it on the smear, incubate the sample, look at the difference, take the history, and look at potential causes and work that up. Okay. Now I'm going to go to a more WBC based example. Dr. Kezia,
Yes, sir.
if you could interpret the CBC histograms and the picture over here. You can start with the
So the
values.
WBC, yes, sir. The WBC count is very high, sir. It's very markedly increased, sir. And the so the RBC count is towards the lower side. HP is 8.2, which is anemic. So the MCV is normal. The MCH is also normal.
Okay. So when you look
Sir,
at this, there is anemia. Platelets are essentially
yes,
okay.
sir.
Leukocytosis is there, right?
Yes, sir.
So I'm going to go on to the
Sir.
smear. Okay.
Smear.
Can you tell me what is this cell?
Yes. So these are the
This cell WBC
the
is what
black.
cell? This one, which I am pointing with an arrow.
So 1 second, it is not. So it is not coming.
It's not
It's
there.
the neutrophils, sir. So
Okay.
yeah, the hypersegmented neutrophils.
Excellent. That is one.
Neutrophils.
Okay, I'm going to point
Yeah.
out at one cell and you have to tell me. Okay, step by step.
Yeah.
Okay. So Dr. Akash.
Yes, sir.
Sir.
Dr. Akash, what is this cell?
Lymphocyte, sir.
Excellent. Okay. Dr. Sudeshna, can you tell me what is this cell?
So band form.
So band form or a metamylocyte going to a band form, you're correct. Similar one is over here. Okay.
Yes, sir.
Then Dr. Swarupa, can you tell me what is this cell?
Sure. So 1 second.
Brownish color
Blast,
granules.
sir.
Okay. It's a little difficult, but you know, this area is the nucleus. And there's a lot of these brownish color granules. A difficult cell. Ignore that cell. Forget it. Can you tell me what is this cell? Size is of a lymphocyte. It has this blackish color granules. Similar cell is over here.
So
Anyone else can tell me what this cell is?
Basophil.
Excellent.
Basophil.
yes,
Okay.
yes.
Dr. Harini, what is this cell?
Myelocytes.
A little off over here, so maybe a promyelocyte.
Promyelocyte.
Excellent.
Promyelocytes.
So yeah, sometimes it is difficult to differentiate. Like if you have a nucleoli or a HOF, we label it as promyelocyte. If there is no HOF or a nucleolus, we label it as a myelocyte. Okay. So now, all in all, this patient has a high WBC count, normal platelet count, leukocytosis, left shift, and basophilia. What are we dealing with?
CML.
Answer.
CML.
CML, sir.
Okay, so potentially a case of CML chronic phase. So sometimes just looking at the WBC, I can't say it is a leukemia, lymphoma, or a CML. But today we are not discussing the scattergrams. Otherwise, if you know how to read a scattergram, this is the position of neutrophils. This is where immature granulocytes come. I would have said this is leukocytosis with left shift. Machine has given a flag which is called as IG flag, immature granulocytes. Basically, whenever it sees cells in this area, which are high, big in nuclear size and granularity, it gives this IG flag, which tells me there is a lot of immature granulocytes. So yes, I confirmed that on the smear. I saw leukocytosis with left shift, basophilia. What is the test we'll advise Dr. Shubham to confirm if it is CML? A single test which you would advise?
BCR radiant.
PCR
By what?
BCR radiant.
Which method you can do BCR-ABL by?
Flow cytometry.
Flow cytometry. Flow cytometry you cannot do BCR-ABL.
These
Fish.
Fish?
Fish.
That is genetics. So you can do it by karyotyping, conventional karyotyping, and look at the 922 Philadelphia chromosome. You can do a fish probe, or you can do a molecular test which is called as PCR. In PCR, you can do a qualitative test which will tell BCR-ABL present or absent. It will also tell you the primer type, whether it is 190, 210, 230, or you can do a quantitative BCR-ABL. But for diagnosis, we generally use either fish and or qualitative PCR, because first we want to prove it is there or not. Then we can measure the transcript level. Okay. So Dr. Shubham, you are there? Okay. Dr. Akash,
Yes, sir.
can you interpret this case 12?
1 second, sir.
WBC count?
Sir, WBC count is increased. That means it is leukocytosis, and except that it is a nomocytic picture. Hemoglobin is since
Fine.
female
Female
patient
patient, she
12.2
was
is enough.
73 years old female and came
So
for a health checkup.
nomocytic picture except WBC.
Except. Now, based on the differential or the histogram, can you tell me anything?
So there are some
In
abnormal.
this histogram, these are eosinophils. This is the position of neutrophils. This is the position of monocytes. And this is the position of lymphocytes. Which cell do you think is more? Which color cell is more?
Sir, lymphocytes, sir.
Okay.
Sir, there is anal reversal, sir.
See
On the
this?
basis of CBC.
Lymphocytosis 88%.
Yes. Yes, sir.
So absolute lymphocyte count is going to be 20,000. Elderly female who came for a health checkup test and has now got lymphocytosis and she is clinically asymptomatic. What will you do next? Make a smear.
Yes, sir. PBF.
What are you seeing?
Mature lymphocytes.
Lymph.
Mature lymphocytes.
Lot of mature
Mature
lymphocytes.
lymphocytes, sir.
Mature
So many mature
lymphocytes.
lymphocytes.
So, what is your impression and interpretation and any advice to the patient or the clinician?
The chronic
Is this normal,
lymphoproliferative
abnormal?
CLL, sir.
CLL.
Proliferative.
Okay.
Sir, there are some smudge cells also.
So, smudge cells mean CLL.
No.
Why do they become smudged?
Fragile.
Fragile, sir.
Any
Vitamins
fragile cell
deficiency.
can become smudge cell. If you transport the sample, it will become fragile. If you keep it for a longer time. So, smudge cells are commonly seen in CLL, but they are seen in many lymphomas, many leukemias, storage artifact. Just because you see smudge cell, please do not call it CLL.
Okay, sir.
And CLL is diagnosed based on what? By which method you will diagnose as CLL? Why is it not follicular lymphoma, mantle cell lymphoma? Why is it not marginal zone lymphoma? How do we differentiate? Which test is used?
Flow cytometry.
So we didn't do flow, so how did we say CLL? So we can say there is a absolute lymphocytosis.
Yes, sir.
It is more than 5,000. And if it is persistent, we should advise flow. On flow, based on suppose the count was 70,000, 80,000 WC, we say, okay, this is a likely to be a chronic lymphoproliferative disorder. Advise flow. Now, in most common condition, especially in asymptomatic, yes, it might turn out to be CLL. Yes, this case was CLL, but on our smear report, you do not label it as CLL. You label this as, at the most, potentially a chronic lymphoproliferative disorder. In view of the absolute lymphocytosis, you would like to do a flow. On flow, if the marker phenotype, for example, CD5 positive, 23 positive, CD200 positive, DIM20, these kind of markers come, we will say this is likely to be a case of CLL. As you said, this patient was otherwise asymptomatic, and this patient might be kept on a close follow-up and till she develops any symptoms. So these are my cases. With this, I would like to thank my team, and I'll be happy to take questions from all of you and inputs from my chairpersons and take questions ahead. Thank you so much for your patient listening. And any questions you have, any